Right. Good afternoon to everyone. Before I start, I would like to wish all the fathers a very happy Father's Day. I didn't even realize till this morning when my daughter came over and said Happy Father's Day to me, and that was nice to hear that message from her. Um, Thank you to everyone for joining the Sunday Life and Learn Talks, which is today is on emotional distress and mental illness. Where are the boundaries? Today's speaker is Professor Nandini Chakraborty. Professor Nandini Chakraborty is a consultant psychiatrist in early intervention in psychosis with Leicestershire Partnership NHS Trust. She is also an honorary professor with the University of Leicester and is an associate dean for Royal College of Psychiatrists. Let's begin the session as I hand over the mic to Professor Chakraborty. Over to you.
Thank you very much, Umeshji, and thanks to Umeshji again for taking the initiative to organize these sessions for the last 1 year. It's an absolute pleasure. He's given me a very kind introduction, and I want to thank you all for giving up your 1 hour on a Sunday afternoon to come and listen to me here, especially on Father's Day. Happy Father's Day to everybody in the room over here. So before I start sharing my slides and going into a bit of a lecture mode, I want to share with you a bit of context and background to the thoughts behind this talk. I work in a psychosis team. So psychosis is my bread and butter. It's a term that we often use in the lay media, and lay people use psychosis or delusional in different ways. But when I started working with a psychosis team, when I first started coming across my patients and relatives, their relatives, I realized just how little people knew about serious mental illness. And whilst we are all becoming very aware about mental health, about good mental health, about being kind to yourself, taking care of your mental welfare, more so over the 1 year with COVID, there has been an incredible focus on mental health, which is extremely encouraging. But there is still very little known about mental illness. When things like psychosis strike people, it comes as a bewildering thing. And not only psychosis, there are several other mental illnesses which have boundaries, gray boundaries with what is not quite a mental illness, but emotional distress. To give a bit of analogy with physical health. So let's say we have some people amongst us who are more physically fit than others. People can run marathons, half marathons. There are others who are happy doing 5K. There are others who can't run at all and go out of breath after running 500 meters. There are many people amongst us who might go out of breath after taking 10 paces, and that's not good. So generally, when we look at good physical health, there are some of us who are very fit, some of us who are not quite, and some of us who, due to lifestyles or diets, are definitely unhealthy. We've got to accept that. But the best lifestyle, the best dietary advice cannot deal with serious physical illness. Let's say if people have genetic illnesses, if people have rare forms of cancer, if people have neurological illnesses like multiple sclerosis, you're not going to cure them by simply advising good diet and exercise. So similarly, in all this talk about mental health, what I want to give you today is an overview about the variety of diagnoses, the differences between what is simply being unhappy, not being mentally well, versus being seriously unwell. Where exactly is it your own lifestyle which can help? And where exactly do you start seeking help from a counselor? And when do you come to a psychiatrist? I think it's important to make these distinctions. So with that, I'm going to start sharing my screen. Okay. Is that visible, Umeshji?
Yes, it is.
Okay, going right to the beginning. Okay. Right. So this is what I was talking about, a few reflections. We like to talk about mental health awareness nowadays, but we are reluctant to talk about mental illness. Psychiatric diagnoses still make us incredibly uncomfortable. Most people draw their understanding of mental health issues, serious mental health issues, from media, films, and fiction, which are mostly inaccurate and extreme. We are getting better at advising people to take care of mental health, but we are still reluctant to talk about mental illnesses. And taking care of your own mental health is not enough. As a society, we need to be aware, we need to be empathic and support people suffering from serious mental illnesses if we are to make a change. So when we talk about mental illness, there's not just one factor. This is a good chart to let us understand the various factors which contribute to mental illness or mental wellness. There are biological factors, which is the chemistry in your brain, genetics, chemicals. There's the psychological factors, which is our own personality, how we grow up as individuals, childhood experiences, how that impacts on our basic self-esteem, attitude towards life, whether we are pessimists, whether we are optimists, and the social and environmental factors. For example, people encountering a disaster, people encountering something difficult, traumatic in their lives at that point. COVID, for example, what we've gone through in the last 1 year is a huge social environmental impact, not only because of the restrictions of lockdown, not only because of the fear, the unpredictability of what is happening, the practicalities of people losing their jobs, losing their businesses, losing what they have worked throughout their lives for. So with every mental health issue or mental illness, there are these three factors influencing them. And depending on what we are talking about, one factor or more might be the major part, whereas the other two factors might have adjunctive roles. And then there is the stress vulnerability model. What we mean by this is there has always been a certain vulnerability that we are born with. So some people are, for simple words, born more resilient than others, whereas others might have more genetic vulnerability. If you look at that graph, when you go towards zero in vulnerability, it takes a large amount of stress to unlock the symptoms of mental illness and cross a threshold. Whereas as vulnerability increases, a low amount of stress can be enough to unlock it. So let's say we have somebody with a high genetic load of clinical depression. Now, if that person loses a job, it might be enough to set off clinical depression, whereas another person going through the same circumstances might have a few days of feeling not so well, feeling a bit sad within themselves, but then generally come out of it. Similarly, if somebody has a family history of schizophrenia, family history of psychosis, it might be that a huge pileup of stress at one point unlocks a psychotic episode, whereas somebody without those genetic factors doesn't become psychotic, again, can go through a few days of not feeling quite themselves, but then they start feeling better. Now, this graph doesn't touch zero for the stress. What it wants us to understand is that there will always be a certain amount of stress needed to unlock the vulnerability. But think about our lives. Think about the kind of stresses we come through. It's practically impossible to go through life without stresses. Every morning we get up trying to juggle our lives. We are trying to, do the lunch boxes, get the children off to school, trying to get on work in time. And that is continuous. We encounter that 5 days a week, 5 days a month, for years and years. That's stress. But because that is daily stress, because that is what everybody goes through, we sometimes don't even think about it. People go through exams, people go through job interviews, people go through life events. And sometimes for people with high vulnerability, these normal stressors, let us say normative stressors, might be enough to unlock a mental illness. So with that, I want to share a snapshot amongst the hundreds of mental illnesses which are classified in various systems. I just want to pick out a couple to give you a flavor of where we've got to distinguish between distress and an illness. And the most common one, perhaps, is unhappiness versus depression. So what is clinical depression? Clinical depression is a combination of symptoms. And what are these symptoms? There has to be a 2-week persistent change in mood. So we are talking about a consistent change, not a low mood, which is coming and going. And within this 2 week, so there are core symptoms of low mood, reduced energy, loss of interest and enjoyment. And there are multiple other symptoms which we can all relate to at certain points in our life: reduced attention and concentration, reduced self-esteem, self-confidence, feeling guilty, feeling unworthy, being pessimistic about the future, at the extreme, having thoughts of self-harm and suicide, disturbed sleep and appetite. But let's say when somebody goes through a difficult situation in life, they can have some of these symptoms, but not most of them. And even most of them, in their most unhappy, will still be able to take some interest, some enjoyment in things going on around. Or their low mood will fluctuate. There are times when it seems overwhelming, but there are times when if a friend comes for a coffee, they might feel a little better. But the thing with clinical depression, what is important to understand is that this is a chemical change in the brain. You don't ask people with clinical depression to simply snap out of it. And that is the understanding that people with clinical depression need. Their depression will be out of proportion, out of context to what is happening in their lives. And people will come to them and say, I can't understand why you're depressed. You've got everything in life. You've got a lovely family, you've got a good job, you've got a good house. And these poor people themselves are struggling to understand, why is it that every time I wake up in the morning, I'm within this black hole? It makes them feel even more guilty that there are people around who don't have as much as I do, and yet I'm feeling this way. I'm a fussy person, I'm a bad person. That adds on to their guilt. But that is the nature of clinical depression, that black hole. And what I'm trying to bring out over here is that whilst you don't want to call any kind of unhappiness, any kind of distress as depression, you don't want to miss clinical depression as somebody who is simply unhappy with their lives. It's important to make that distinction and get the help. For somebody being unhappy with a particular factor in their life, it's a more problem-solving approach we need. What is wrong with their life? Let's get heads on. Let's solve it together. We need the counseling. We need to support them to make those changes in life to bring them out of unhappiness. When we are talking about clinical depression, we are talking about psychiatric treatment, a combination of talking therapies and medication. And there is absolutely no shame, no feeling of being an unworthy person or being a weak person if people in severe clinical depression need medication. The symptoms of any mental illness, depression included, are marked by changes from baseline personality and activities. So let's say somebody has always been quiet, has always been an introvert. We don't expect treatment to absolutely bring them out of their shell. We've got to give respect to what people actually are by their baseline. And it is this change from baseline. Somebody who used to be outgoing suddenly becomes a recluse. Somebody who used to be very active on Facebook can't find the motivation to put their posts at all. It's interesting, social media gives us a completely different perspective of behavior nowadays. You can almost look at somebody's post sometimes and make out what might be going on. That's just, on the side. The changes again in clinical depression are, again, it's persistent and it's out of proportion to circumstances. And whilst we are going through COVID again, there is a lot of grief around us, a lot of bereavement. And grief, again, is one of those realities in life. All of us, in some capacity or the other, in some position of the other, will go through grief. And grief is normal. It should be differentiated from depression. Grief can lead to depression in the vulnerable, in people who have that propensity to developing depression. But we've got to understand grief as a normal human phenomenon and not call these people depressed. They are grieving, they are bereaved, and we've got to support them to get through a normal bereavement. The key difference in grief is that people are still connected to others. They don't necessarily think about themselves as a bad person. They don't necessarily think of themselves as unworthy. There's simply this yearning, this missing the person who has gone from their lives. And even within that yearning, within those waves of sadness which come over them, there will be some waves of relief as well. When they connect with dear people, when they think about some good memories, when they think about what they might have achieved in life and the memories that they have shared with the person who is no longer there. And it is a normal process which will run its course and people will come out of it. What we need to support them over there is not to send them to a counselor, not to send them to a psychiatrist, but support them and reassure them that this is a temporary phase, they will come out of it, and to understand the stages that they are going through. So again, when we are talking about unhappiness, let me reiterate some of these points over here. It is proportionate to circumstances, it has context, mood still fluctuates, it's self-limiting, and the person will still have positive outlook on some aspects of life which are lost in clinical depression. Let's go on to a completely different topic in child health, the naughty child versus ADHD, attention deficit hyperactivity disorder. And the reason why I've chosen ADHD is that I'm coming across people more and more within my patient load who have had ADHD from childhood. ADHD has to be there from childhood. It's not something which suddenly comes at age 18 or age 21, but they have suffered throughout their school lives being labeled as naughty children, careless, people who don't listen to their teachers, who don't sit still in one place and have not got the correct help and have come to adulthood underachieving compared to their usual potential, to what they could have achieved. And what is ADHD? Again, this is a chemical change in the brain. The way it works is that there are certain parts of the brain which have less blood flow compared to normal in people with ADHD. And it might seem counterintuitive that, why is it that people with less blood flow will become hyperactive? And the reason is that the brain spends an awful lot of energy and a lot of effort in trying to filter information that comes to us. So we are all the time being bombarded with stimuli, but we can focus on the task at hand. At this point of time, if you listen very, very carefully, your laptop is probably giving off a buzz. There's probably light coming in through the window. There's probably the sound of another electronic device behind you. But if I am doing a good job, you're listening to me. You're listening to my voice and this presentation, and you're concentrating on my slides, fingers crossed. But somebody with ADHD cannot filter that information because there are parts of their brain which are not working the way they should. And the symptoms over here are inattention. So they simply cannot focus their attention. Their teachers will be scolding them till the end of the day saying, can't you pay more attention? Can't you sit still? There's the hyperactivity. They physically just can't stay in one place. and impulsivity. They will suddenly blurt out answers. They will suddenly blurt out something which is socially unacceptable. And that continues into adulthood. In adulthood, people learn to make it more socially acceptable. So as a child, they would be running around the classroom. They will be running around at home. They never sit still on the sofa. And when I say never, I mean never. In a 5 or 6 year old child, of course, you would expect them sometimes to jump on the sofa and jump on the bed, but you don't expect them constantly, going around the room. But an adult knows that that is not socially acceptable. So what they do is they will deliberately avoid cues. They will deliberately avoid tasks which involve them sitting in one place for an hour or so, or they will make excuses. If somebody says, can somebody make tea? Okay, they'll jump out of the seat. I'll be the one to do that, because they have to relieve that, that feeling in their legs, in their body, or they're constantly making excuses to go to the toilet, or constantly saying, I'll go out of the room and do something. And that's how it exists. But their lives are extremely chaotic. They lose things. They are always late for appointments. Their rooms are untidy. Everything is disorganized. And it is this constant theme of disorganization to the extreme. Again, some of us are more organized than others. There is a range, but within ADHD, you're talking about somebody whose life is on hold, who don't sustain jobs, who don't sustain relationships, because life is such a chaos. These are some of the diagnostic symptoms that we have basically talked through. And so there has to be clear evidence, as with any mental illness, that the symptoms are actively interfering with quality of life, with the level of functioning. And then moving on very quickly, we've talked about, depression in adults. We've talked about ADHD in children and adults. I want to move on very quickly into another aspect of, of illness, and that is dementia. Now, often dementia is taken as part of normal aging. And yes, people can have normal aging. We get forgetful as time goes by. But dementia is beyond this normal forgetfulness, normal aging changes. It's a term for a group of symptoms that occur when the brain is damaged by diseases. Alzheimer's and vascular, so that's when the blood vessels get blocked, are the main categories that we are talking about. But why is it important to diagnose dementia? Why can't we simply accept it as, okay, this is something that happens with older people, they have to be taken care of, and you can't cure dementia anyway, so, why should it be identified? Yes, dementia is progressive. Dementia cannot be cured, but there are medications which can work for very short periods of time in the early stages to extend the process, to delay the process, which gives the person a few more years with quality of life with the family. So at least to give them time and indication of what is happening, what is on the way, is just fair to them, so that they can put their affairs in order, so that they can do the things that they wanted to do. They can give power of attorney, they can sort their legal matters instead of leaving it till the end when they are starting to lose mental capacity. So that's why dementia is the progressive illness which impacts on not only a person's memory, but their functioning in terms of how they organize their lives, their attention, concentration, prioritizing, executive cognitive functions, as we call them, and these are beyond what would be normally expected for a healthy person at their age. Early identification means that there can be some treatment which can delay the process, and people can prepare themselves for what is coming in future. And the last category I want to talk to, and as I said, this is my bread and butter because I work in early intervention in psychosis. Psychosis is a generic term. It's not just one illness. For example, if you say hepatitis, you're not talking about one illness. Yes, you are talking about inflammation of the liver, but you are talking about, could be infections, could be bacterial infections, viral infections, it could be alcohol induced. There could be a number of reasons for the inflammation of liver that we call hepatitis. Similarly, psychosis is a general term for a group of illnesses which indicate a break from reality. And when we say break from reality, they suffer from symptoms, mainly delusions, where they have false fixed beliefs, which are not connected in any way and logic to reality. And they can have hallucinations where they are hearing or seeing things which are not there. These are the two main categories of symptoms that they have. And it's a set of, psychosis is a set of symptoms rather than the condition itself. But there can be illnesses which are psychotic illnesses and are types of psychosis. And they have more specific diagnostic criteria in terms of how they come about, what kind of symptoms they have, and how long that they exist for. So, for example, when I talked about clinical depression, duration of the symptoms is an important point for diagnosis. For clinical depression, symptoms need to have lasted persistently for at least 2 weeks. Similarly, for schizophrenia, the symptoms have to last consistently for 6 months. Delusions and hallucinations are not coming and going. People can have very brief transient delusions and hallucinations, let's say under the influence of drugs, but you don't call that a psychotic illness as such. Illnesses like schizophrenia exist across the world, and that is the basis, the validity to say that these are real mental illnesses. These are not simply explained by somebody having distorted explanations to life because of difficulties they've gone through, or this is not simply a culture bound syndrome. This is something that exists across the world in all social classes, in all cultures. The content of their delusions can vary. So somebody in, let's say, a Western culture might talk about aliens or being under surveillance and cameras, whereas somebody from a more rural background in a lower and middle income country might just stop at saying that people are following them around, or something is happening to their body which is influenced by maybe ghosts or curses, etc. So the content can vary, but the basic theme of feeling persecuted, the basic theme of feeling that they are in danger or picking up messages across the environment which don't exist otherwise, is similar across the world. The gender prevalence is generally equal, but what we are noticing is that towards the younger age group, between the teens, 20s, early 30s, we get more patients who are male, whereas in the later years, in the 40s, 50s, we are getting more women. That's just an observation. So most schizophrenia or bipolar affective disorder will develop in teens and 20s, but they can occur potentially at any age, and we do get them well into the 40s, 50s as well. Now, what are the myths? Schizophrenia has got nothing to do with split personality, even though it comes from a Latin word which translated means split mind. But this has caused confusion, but it's got nothing to do with split personality. I've never come across split personality in my practice at all, as seen by various films, etc. I must say that. And when people with schizophrenia or any other kinds of psychosis like delusional disorder or acute and transient psychotic episodes get the correct treatment at the correct time, they do very well. People lead absolutely normal lives. Some of them will need to have medication for the rest of their lives, but with that medication, they have an absolutely excellent quality of life. There's nothing to say that they are having a serious mental illness in the background at all. And think about people with diabetes or people with asthma. It's not that the diagnosis will go, but with the correct medication and the correct support, They live lives with quality of life and no symptoms. You can manage their symptoms with medication. And that is what you need to understand about psychosis and schizophrenia. People with schizophrenia are not inherently dangerous because they have schizophrenia. Lots of crimes in every day, in every society, are committed by people with no mental illness. It is simply unfortunate that every time somebody with a diagnosis of paranoid schizophrenia commits a horrific crime, the newspapers are the first to relate that. And so people have this kind of image in their mind that somebody with paranoid schizophrenia is immediately dangerous. No, they are not dangerous. Some people might have delusions which make them feel very threatened. So sometimes the crimes are committed because they are defending themselves. They see themselves as, being under threat for their lives. And so what they are doing is trying to stop other people from killing them. And that happens with a very, very small proportion of patients, real minority, and that is not the mainstay of schizophrenia at all. Most people with schizophrenia are actually vulnerable from exploitation and harm from other people than they are as a risk to others from themselves. So this is just the definition of schizophrenia as per nhs.uk. But let me give you a more human aspect of what I see with psychosis and schizophrenia. So let's say you've got this young person, a young man living with his family. They've all got well together for years and years. He has a very good relationship with his parents. They get along fabulously. He's very close to them, confides in them. And suddenly, gradually, the parents start noticing that this young man is withdrawing from them. He suddenly doesn't want to share in their family meals. He suddenly starts accusing his mother of poisoning his food. He suddenly starts accusing his father in being in league with the government and putting cameras in his room, and that his parents are in cahoots with people who actually want to kill him. And the parents are left bewildered because society generally does not know about psychosis. As I said, they don't understand what is schizophrenia, what is psychosis. And the parents are likely to be absolutely bewildered at why their young, intelligent, well-functioning boy, he doesn't even do drugs or alcohol, he's always been a good boy, suddenly, why is he behaving like this with them? And they are left probably trying to analyze, was there something wrong in our relationship? Have we done something wrong? Have we hurt him? Was there something wrong in the upbringing? Or maybe he's in university, he's doing well. Did we pressure him to go into university? Did we pressure him to try and find a good job? Are we at fault over here? These are all questions that parents I've usually see ask themselves. But actually, it's nothing to do with their parenting. It's nothing to do mostly with trauma. If there has been trauma in the background that has brought it out, usually it is the normative day-to-day trauma gone on for years for a young man who is otherwise extremely capable and intelligent. And because of that genetic vulnerability that he had to schizophrenia right from the beginning, years of that normative stress have unlocked it. It's got nothing to do with his parents' behavior. It's got nothing to do with their relationship. But you can imagine the impact that accusations of this kind will have on a relationship. The impact that continues on when somebody is not willing to admit that they are unwell, that they need help, that they need medication, and the circumstances that it leaves the family in. It's absolutely heart-wrenching to watch. But to give you and my overall key messages, as I said, not everyone going through a difficult time needs counseling. Sometimes just as friends, having a coffee, bringing some flowers, giving somebody an encouraging card when they are going through a good, when they are going through a difficult time is enough. And not everybody having a low day is suffering from depression. But on the other hand, when people have serious mental illnesses, don't expect them to pull out of it. Don't tell them to get a grip on themselves and pull their lives together. Good work life balance, healthy practices can help common mental health issues, just as having 30 minutes of exercise a day and good diet can at least help us prevent type 2 diabetes, cardiovascular disorders. They can keep us fit and healthy and help us to enjoy a better life. But it's not going to stop rare serious illnesses if I have that within my genetic makeup. And similarly, good work life balance and healthy practices can help common mental health issues, but it does not cure or prevent all mental illnesses. We've got to understand mental illnesses and encourage people to seek help at the right time, be empathic, and not judge people. So many times I've seen parents of young people with psychosis or ADHD or going through clinical depression be so reluctant to mention it to their extended family, to their friends group, because immediately people are judging. Oh, what's wrong in the family? What's been happening? Have the parents done this? Have the parents done that? Oh, the children must have taken drugs. We are so quick to jump to conclusions about what must have caused the mental illness without recognizing the biological background behind a lot of serious mental illnesses. And so, what can we do to help? We support people as we would do in normal human kindness. We don't have to psychoanalyze anything. We don't have to always give a label, a psychiatric label to everything, but simply just be there for people, have an open mind, be empathic. We have to be aware of the existence of mental illnesses and encourage people to seek professional help where appropriate. Don't rush to conclusions. And ultimately, the biggest message I want to share with this group today is don't stigmatize. Mental illnesses are as real, as valid as physical illnesses. The same illnesses exist throughout the world, as I said, in different cultures. And what could be a bigger proof of their validity? They are very variable. One person's mental health issues are not the same as others. There's a wide range over there. So let's have an open mind before we jump to conclusions. And that's the end of my presentation.
Thank you so much, Professor Nandini. Really wonderful presentation, so informative as well. We've got a few questions in the chat, so if I can read them out to you. Um, right, the
Sure.
first. Um, right, let me take them as in the order that they have come through. So the first one is: can a person be hyperactive and impulsive but without ADHD?
Yes, and being diagnosed with ADHD requires very strict criteria. And there can be people who have some of the symptoms, not all, and they are not consistent. Also, let's say there can be other mental illnesses like manic episodes where people are hyperactive and impulsive just for short periods of time. It's a change from their baseline personality rather than being there all the time. So when people, if you, my simple answer to David's question is yes, but I would always consider context, background, duration of symptoms when coming to a conclusion about what is it about one particular person. And yes, somebody can be a very active and just impulsive person with no diagnosis at all. Absolutely accept that.
Okay, thank you. Uh, Another question: if there is someone who has first episode of psychosis and believes it is so real, how can one get them to see a doctor to discuss this? And how do you tell their family?
Yeah, I think having a discussion with their family, a gentle discussion with their family is probably easier. And family will know what is happening. You don't live with somebody with psychosis and know nothing about it. You know, it's a very obvious condition with very obvious symptoms. If the family are living with the patient, they will know that things have changed, and probably they are already trying to get the patient to see a doctor but failing, because most of the time the patient believes that that is the crux, the absolute point about psychosis, that for them it is an alternative reality. They don't see anything as wrong within themselves, everything is wrong with the world, which is trying to do terrible things to them. So sometimes it's about using gentle case by case techniques. So telling the person that, okay, I'm not disputing what you say is happening with you, even though I can't completely agree. We've got to agree to disagree over there, but you are under a lot of stress. Why don't you just talk to your doctor about that stress level that you're under, and at least get them through the GP's door in that manner? Or perhaps asking the GP to do a home visit. Sadly, a lot of patients come to us after a mental health act assessment and after their first admission, because they will absolutely not take treatment otherwise. But generally, those are the two techniques I can talk about, that at least getting them to talk to somebody about the stress that they are under, or secondly, getting the doctor to make a home visit.
Thank you for that. There is another question, a bit of something that has been noted, but also a question within that. And it's from Peter Bell, who says, I have a brother who has lived with schizophrenia since the age of 18. And after some years spent finding medication that suited him, he has lived a normal life since then,
Mhm,
which is really a great story.
mhm,
He also sings in a choir. So Peter also sings in a choir with somebody else who has lived with schizophrenia all his life, but finds it restricting what he can do or what he thinks that he can do. Peter further on says that we all have voices in our heads all the time, although after lots of meditation, he particularly has fewer voices and more calm periods. So the question is, what is the difference between normal voice, the destructive or negative voices that somebody hears?
yeah, yeah. So that is absolutely a great question. And because we get lots of patients referred by their GP saying that they are hearing voices in their head. And hearing voices inside the head, which we identify to be our voices, our internal monologue, is not abnormal. It's an absolutely normal human phenomena which does not have to be pathologized at all. The voices I'm talking about, quite interestingly, and this, if I give you a snapshot from anonymously from some of my experiences, people will actually say, I don't hear voices. It's actually the neighbors next door who are talking about me. Or it's not voices. There is, a complex mechanism by which people are sending electromagnetic waves in the air, which only I can hear and nobody else can hear. And that's why it makes me appear to other people like I'm hearing voices, but that is being conjured for me. The point about a hallucination is that it is a sensation, it is a perception with the real substantiality of a real perception. Let me give you another example. Perhaps that will explain a bit more about what a hallucination is. Um, a phantom limb can happen when people lose their limbs in an accident, let us say. So let's say if I lost this hand in an accident, even for a few days to a few weeks, sometimes a month, I would be able to feel the entire hand and fingers. to the point that people even experience pain in phantom limbs. They can even experience, movement. Now, why is that happening? That is happening because let's say I've got a nerve from the tip of my finger over here, which goes right through my hand and it traverses all through my hand, right up to my brain. And then there is a point in the brain which is, receiving that nerve from the tip of the finger. And when I touch my tip of the finger, that part of my brain is getting, sparked by electrical impulse. And my brain is telling me that something is touching your finger over here. So what I'm perceiving is not always what is happening in the environment. It's what my brain is telling me. So when this hand is, let's say, lost, the nerve that used to come from that hand is truncated. It's there at the wrist. But when something is striking that nerve and it's going up to the brain thinks that's the nerve that comes from the finger. And it's still thinking that the middle finger is moving or being touched, etc. So similarly, when people hear voices, what's happening is that, so we've got a temporal area of the brain, a temporal lobe of the brain, which has the hearing receptors. So there's sound waves which strike our eardrums. They carry those impulses through the auditory nerve, through the hearing nerve to the brain, and then the brain picks up those impulses and it hears. Now, let's say, hypothetically, if there is a chemical change in the brain where there are no waves, there's nothing coming from outside, but due to that chemical change, the temporal area of the brain, those hearing receptors are getting sparked on their own. The sensation to the person would be exactly like if somebody was standing near them and talking. And people will be incredibly detailed. They will tell you somebody 3 doors down is talking about them 10 o'clock at night, and this is what they are saying about them. This is the full-blown conversation they are having about them. There are, families I've visited, patients I've visited, I've seen, their house around seems a completely quiet neighborhood. I've not heard a thing whilst I'm sitting there. Whereas they are sitting there telling me right now over there in that household, I can hear, and I'm not interpreting, I'm not making up things. I can actually hear the couple having an argument. And this is what they are saying. So that is what we call voices in the psychotic sense. So that's very, very different from the voices that we hear in our head. Absolutely, there's no comparison at all.
Okay,
I hope
thank you.
yeah.
So, just a follow-on question. There is also the question of what is my reality, as I know that all of my sense organs have their input filtered before it reaches my conscious mind. Is to say that my filter settings are the best or right ones?
Yeah, yeah. And that is exactly what I was talking about. The world as we perceive is what our brain tells us. And I think the simple answer to that is that when multiple of us are hearing the same thing or seeing the same thing, we assure each other that that is the right perception. If there are 10 of us in a room and none of us can hear a chatter outside the door, but one of us can, then we conclude that one person is having auditory hallucinations where they can hear a chatter outside the window. It's a very philosophical question. And I also always wonder that, yes, of course, the world is what we perceive around us. And it's not only about hallucinations, it's about how the delusions come, how the beliefs come. So a detective, a good detective or a good intelligence officer is obviously going to pick up patterns and, people behaving in certain ways, and they will see certain things in a room that you and I will never see. But when they explain it, it makes logical sense. But when somebody with delusions tells you that, what is happening, you know from their logic that this just doesn't fit. I'll give you an example. So let's say the patient's initials are, I'm just saying anonymously over here, AB, right? So there was one time when the car number plates were in a series that went ABD, the patient's initials. And so that the patient concluded from that, that this is a conspiracy which shows that, which is saying AB dead. So that is what the car plates mean. Right. And because the series are coming out like that, that is the conspiracy, closing in around them. And every car plate is significant. And that is the kind of message they will pick out, which is very different from what a detective or what an intelligence officer would explain. The other thing about delusions, and again distinguishing this from people who believe in conspiracy theories, people with conspiracy theories are not delusional. I'm not labeling anybody as mentally unwell, even though I might not agree with what they are saying. And the difference there is that delusions in mental illness are extremely turned inward. So the person is always in the center of it. Something particular is happening to them. It's not generally about the world or world patterns. Lots of people believe that we are under surveillance. Of course we are. I know we are. The government has lots of information in the database about us. But I don't believe that I am under surveillance any more than the average person on the street. Yeah, it is what it is. So, but if I started believing that I am targeted for a particular reason, something is special to me for a particular reason, then that is what becomes delusional. That is what becomes abnormal. Yeah. So yes, there are ways of distinguishing what is normal human experience and what is psychotic experience, and I've learned it over years and years. We often come up with these questions about, nowadays with technology, people can be put under surveillance so commonly. How can you make a difference between what is delusional and what is not? But yes, there are ways of looking at it in more detail.
Okay. So we got another question, and that question is: my son is withdrawn now and locks in his room, doesn't talk to us. He's very tearful and feels no one understands him. NHS has not helped. He is very intelligent and doesn't want meds after research. What do I as parent do, um, as he doesn't want us to be involved and has excluded us with everything?
Okay. Right. And I would desist from giving very particular specific advice without knowing more details. And
Sure.
I don't think that is within the remit of this talk. But what I would say as a first starting point is that the GP absolutely has to see this young person to make a start of referring on to mental health services. If at any point we feel that the person lacks insight, again, another philosophically very debated term, but I won't go into the details of that. But, if we feel that somebody is unwilling to accept help, but they should, and as family, we have concerns about their risks to themselves or others or both, then families can call out what is known as a mental health act assessment. It's not always a pleasant process, but it's the process by which two doctors and a social worker will come out, see the patient, and if the patient has to be admitted to hospital, they can do it against the patient's will, or that process itself might convince the patient to start engaging with services. It's not it doesn't always sit comfortably. It's something like saying that, either you accept treatment, either you accept help, or we are going to admit you to a psychiatric hospital anyway. But at least it's better than leaving them without any help at all. So calling out a mental health act assessment by the family is also possible. You don't always have to refer through GP or doctors. it's got to be what's called the nearest relative. So out of if it's a young person, then the out of the parents, whoever is the older one living with the patient is technically the legally the nearest relative. So they can call social services and ask for a mental health act assessment as a last resort.
Thank you for that. So, next question: are there any nutritional deficiencies associated with mental health or chemical imbalances in the brain, blood vessel health? Do you know of particular supplements and natural treatments that can help elderly persons with dementia or people with diabetes, Parkinson's, and long term clinical depression?
Okay. These are all very varied illnesses. So, there's definitely not a single diet that can kind of cover everything. So, I wouldn't say that there are any specific diets or specific supplements. I think a good, balanced, healthy diet for everybody, taking your fruit and veg, making sure you have enough minerals. Vitamin D deficiency is a very common thing that we come across. Having omega-3 fatty acids, making sure that people have the good fats versus the bad fats, having more fresh food than processed food. These are all general guidelines that everybody could do with. Now, it's not that it's going to help advanced Parkinson's or advanced dementia, but let's say in early stages, it could help anybody.
Okay, thank you. All right, so the next question I have is okay, somebody who is a psychiatrist, and he says a significant challenge is early identification of potential mental illness and only gets to the attention of professionals at the latter stage, at the later stage. Can Professor share with the audience the benefits in outcomes if doctors are involved earlier and how people can get advice if they don't trust their local system of support?
Absolutely. I mean, that is what early intervention in psychosis is all about. The reason why early intervention in psychosis services were set up was because it was recognized this is one of the most serious groups of mental illness, one of the most vulnerable groups of people, and that there has to be intervention in those first 3 to 5 years, which is crucial to prevent future decline in what we call negative symptoms of schizophrenia. When people start withdrawing into themselves, they lose motivation, they become more asocial, they lose that higher cognitive function of trying to organize their lives. And to prevent these negative symptoms from coming along, early intervention is extremely important. I think we have to target early intervention in all mental illnesses, not just psychosis, because we need to cut short human suffering and the impact it can leave on people's lives if they are untreated for years. Let's say in case of ADHD or autistic spectrum disorder, you're looking at a wide spectrum of illnesses which can play havoc with people's lives. So that is the focus of getting help early, but it's also about getting the right help early. It's not that families don't want to help. A lot of people with psychosis have had families trying to do their best, engage with their children, trying to be kind to them, trying to encourage them to come out of their rooms, or trying to explain to them that no son, no daughter, I'm not against you, this is all in your mind, etc. But they're not getting the right help, because by the time people have serious mental illnesses, they've got to get that help from mental health services. It's definitely beyond just TLC over there. But in terms of getting help from the right services and from their local systems in the NHS, um, I'm not sure. I must say that because we are very dependent on local services. If people can afford it, they can go private. But what I've seen in the private sector, let us say in psychosis, yes, somebody might go and get a diagnosis of psychosis from a private psychiatrist, but then it needs a team to help with various aspects. When you want psychological help, you want occupational therapists to be involved, you want a support worker to be involved, you don't get that coordinated service from private sector. So ultimately, it's got to depend on your local health systems. And I think we need more of these dialogues, more of these understanding, and perhaps lobby for change in our local systems. It's not a magic answer. It's not something that can be achieved within a week. We are probably looking at months, if not years of change. But it is about negotiating with local commissioners, talking to GPs, talking with existing services about how we can improve things. And declaration of interest over here, but I will always say that, in that sense, early intervention in psychosis services do a great job. And as years have, gone around, there have been cuts in services, and often early intervention services have been absorbed back into what are called the generic community mental health teams, which are also professional teams, and the background of the nurses and the doctors in those teams is no different from mine. But, in years of experience in psychosis obviously gives you a different edge. And hence we should all, be in this together and see the advantage of keeping specialized services for specialized illnesses up and going. So I think if we were to lobby for something, it's not just generic services, but specialized services. Recently in Leicester, we've also had a new community autism outreach service, which is beyond diagnosis. It's about support. And it's something that has been, long in the coming, and absolutely crucial for help with people with autism who are not going to respond to medication, but need that coordinated support. So really happy about that. So rather convoluted answer to deep, I think it is.
Yes.
But yep, there we go.
Great. Thank you for that. It's 12:32. There are a couple of other questions. I don't know whether if you don't mind, I'll take one more question because it's quite an interesting one, and it will be useful
Sure.
to know a little bit more about that. So the person says, if the brain has learned that a particular spot on the brain is connected with, say, middle finger, can we unlearn that connection
Mhm.
and reset that assumption that the brain has made? Similarly, with the hallucination, the brain has learnt, and can this be unlearned?
Yes, it does get unlearned. Ultimately, people don't live with phantom lives for the rest of their lives. So, the brain does adjust to understanding, yes, there is no hand over there left. And what helps are the accessory sensations. So let's say, for example, yes, I can feel the hand moving. I can, feel the outline of my fingers. But when I take my other hand and touch where I should have got a resistance, I no longer get that resistance. My hand goes through because I don't have a hand left. So as those kind of sensations are also related to the brain starts questioning, something's not quite fitting over here, because the brain wants its sensations, the information to be well coordinated. So ultimately, yes, the brain does unlearn that. And in terms of auditory hallucinations, I'm coming from a biological point of view as a psychiatrist. The medications do work, and some people need medication for lives. There are others who don't, who need medication for a short while, and that seems to adjust the brain chemistry, which has led to the hallucinations, to the auditory hallucinations. And thereby, yes, we can stop hallucinations from happening. Also, in terms of the brain learning and unlearning, it depends. If we're talking in an overall sense about the brain having a certain learned scheme, if we are talking more about our thoughts, there are certain schemas, we say, that we form as children. A certain way in which we view the world, a certain way which makes us people. And those schemas are very difficult to unlearn. And again, these are not abnormal. These are things which decide whether people are spiritual, whether people are religious, whether people are introvert, extrovert, whether people are trusting, whether people are suspicious. These are, kind of schemas that will probably go for the rest of our lives. So some people might think that you should never trust other people. There might be others who think that you've got to see the good in other people, and these are built by childhood experiences and other subsequent experiences. And there are experiences in adulthood which sometimes challenge our schemas, but we always try and come back to it. We always try and find an excuse to come back to it. But at the end of the day, there can be large life events which change people, and there can be traumatic events which change people and schemas. So yes, the brain can unlearn depending on at what age it did the learning, what is the context of that learning, and its subsequent experiences, and whether they are strong enough to challenge the strength of that learning.
Okay. There are a couple of other questions, but I think it's coming up to 25 minutes to 2 o'clock. And I'm not going to pose any more questions at this stage. So thank you so much, Professor Nandini. It was very, very informative, and there are so many questions. And you've answered all of them. So thank you once again, and have a good afternoon. And we shall speak again very soon.
Okay.
And thank you
Just
to
as
everyone.
an ending thing, Umeshji, there have been some private messages which I've not had um, scope to answer. So what I've put over there is that I am on Twitter at Dr. Nandini C, and I'm contactable there. So if people want to drop me a message, I'll help as much as I can, but you've got to be aware that I don't do any private practice. I will not give any specific advice, but I can certainly direct you to the right pathway if I can.
Perfect, perfect. Because that was one thing I was going to ask you, and then I was going to put it on the chat. But perfect, you answered it.
Okay.
Thank you so much.